Ladies and gentlemen, it is my great privilege and I like to welcome to an ESOT webinar titled Every Thoracic Organ Should Be Procured with Machine Perfusion. I hope that this webinar will meet your high expectations. So first, to introduce myself, my name is Ivan Knežević. I am the head of the Transplantation Center in Ljubljana, Slovenia. I'm the cardiovascular surgeon from Ljubljana, Slovenia. Second thing, I'm also chairing the ECTA. ECTA is the European Cardiothoracic Transplant Association, and the board of ECTA was elected during the ESOT Vienna 2013 Congress. So the organization is very young. And the ambition of the organization is to become a gathering home to foster scientific growth, exchange programs, collaborative projects, and funding opportunities dedicated to European heart and lung transplant programs. So it is my great privilege also to introduce my co-chair, Massimo Buffini. He is a famous cardiothoracic surgeon from Torino, Italia. Massimo, please.
Thanks, Ivan. Welcome to this webinar also from me. My name is Massimo Buffini. I'm a cardiac surgeon at the University of Turin in Italy, and I'm the Associate Director of the Heart and Lung Transplant Program here in Turin. During this webinar, we will have a debate regarding a very interesting issue, the role of graft perfusion in heart and lung transplantation. Perfusion has changed the clinical scenario of thoracic transplantation, and I would say of transplantation in general. And these techniques are gaining more and more importance, both in DBD and in DCD donation. We will have two outstanding speakers who will try to sustain two opposite positions. The question of the debate is if all grafts should or should not be perfused before transplant. Before starting with the debate, some practical information. After the speakers presented their arguments and after their rebuttal, we will welcome questions from the attendees. To ask questions, please use the question and answer button, and the panelists will answer the question at the end of the webinar. I think that we can now move to the debate, and I ask Ivan to introduce the first speaker.
Thank you, Massimo, for your nice introduction. First, before we start, we would like to run preliminary poll to see what is the opinion of our audience. So please launch the poll. So please answer, every thoracic organ should be procured with machine perfusion, yes or no? We're waiting for the results. Okay, now we have 75% no and 25% yes. So Gregor, you are in big challenge. Now I'm going to introduce our first speaker, my good friend, Professor Gregor Warnecke. And Gregor left Hanover Medical School in January 2020. I mean, that was probably bad luck for Hanover and a good option for Heidelberg, where he is now heading the terminal cardiac failure program now in Department of Cardiac Surgery, as I said, in Heidelberg, Germany. And please, Gregor, start with your first presentation titled Every Thoracic Organ Should Be Procured with Machine Perfusion.
Thank you, Ivan, for the nice introduction, and thank you for everybody taking part in this online meeting. So I was asked to give a presentation entitled "Every thoracic organ should be procured with machine perfusion." And as usual with such discussions, I have to say, obviously there are pro and con arguments to doing so, and I'm presenting the pro argument, not necessarily meaning that I'm absolutely sure that we have to do that, but I will try to make a case for doing organ retrievals with machine perfusion for both heart and lung transplantation. So I have to tell you that my conflict of interest is that I've been working with Transmedics, the manufacturer of the OCS heart and lung devices, for many years on a scientific level. So I've also received institutional research grants from that company for doing animal research and travel reimbursement for scientific meetings. So the machine perfusion devices that are clinical grade and actually used clinically nowadays, for the heart is the Transmedics OCS device the only one clinically used. There are more devices in preclinical development, although they are not commercially available, nor have they been used yet. For machine perfusion of the lungs, there's more variety, and we can choose between among different devices. The OCS lung device has the beauty of being transportable. On the other side, it's the most expensive one of the ones that are available. There's also the ex vivo device as used by Shefke Chefji in Toronto, and he's obviously well known for doing that. And the VivoLine device that is also stationary and is also a very good ex vivo lung perfusion device. So what are the current limitations of preserving thoracic organs? So there's standard cold preservation, cold storage, and we have time-dependent injuries, so ischemic injury on the organs. We cannot work on the organ to improve it during preservation before implant. And also we don't have any tools of assessing the organ viability. From the moment we put the organ on cold, we have to believe in the fact that the organ will start to work perfectly again after reperfusion. We have no means of assessing the organ if it will perform well in the recipient after cold storage. So the result of that, and also of other factors, is that of 10 donors, only 2 to 3 are used for thoracic donation. That's a little better in Europe than in North America. But overall, if you look at liver transplantation numbers, for example, there are always 2 or 3 times the number of heart and lung transplantations, meaning that there are many donors that are not used currently. So what is the impact of heart ischemia time? We all think of heart transplantation having to take place within 4 hours of ischemia maximum. So meaning from putting the clamp on the donor to releasing the clamp in the recipient should not be more than 4 hours. This comes from data showing that there's an exponential increase in bad outcomes with increasing cold ischemic time, picking up after 3 hours, but really being a steep increase beyond 4 hours. So what can the OCS heart, and I'm coming in my talk first to heart transplantation, what can the OCS heart do for us? It can reduce ischemic injury because cold ischemia is not as long. We can have warm perfusion instead of cold ischemia. We can hopefully also optimize the organ condition in some circumstances, and we can assess the function ex vivo using the device. And I will come later to how we do that. So there has been the PROCEED-2 study, and I'm just citing that because that's to date the highest ranked publication for the OCS heart, published in the Lancet. And that study is more a con argument for doing all organ heart procurement in that setting, and taken the number of patients studied in that study, there was not a difference in outcomes using machine perfusion versus cold storage. So if we look at one of the next publications coming out from Andre Simon's group from Papworth in London, the Bromley and Harefield Trust, I was going to say, in London. Andre's group published data on using the OCS heart in extended criteria heart donors. And this was a non-randomized study, a single center experience, but publishing the first 26 high-risk transplants with extended criteria donors and high-risk recipients. And they showed very nice outcomes with very good survival of the recipients in their study. And from there on, we did quite a bit of research in extended criteria heart donors. There's a extended criteria heart in multi-center trial ongoing in the US. Inclusion has concluded now. That is the Expand Heart trial. And they had multiple extended criteria donor criteria as inclusion criteria into the trial. The recipients, about half of the recipients, more than 60% actually, they're on left ventricular assist devices, so they had previous cardiac surgeries. And 1 year survival in that study was quite good, was 58%. This is only preliminary data. The final publication is coming out soon. So if we look at DCD transplantations, you all know that the OCS heart has been used in DCD heart transplantation, has actually been the very tool enabling DCD heart transplantation. This is a slide that's a little while ago. 100 successful DCD heart transplants were done at that time, although the number is much higher now. It's not possible to do in Germany, so I have no, for legal reasons, I have no personal experience in doing that. But in Great Britain and Australia, and also in Austria nowadays, in Belgium, there are programs ongoing doing DCD heart transplantation with very good results. So machine perfusion in all heart transplantations, is that really necessary? So I have showed you data showing in extended criteria donors good outcomes, DCD heart transplants, also recipients with previous cardiac surgeries. That's something we have done in Hanover a lot in recent years, using the OCS to having more time to do the meticulous surgical preparation in recipients with previous surgeries, which make up to 80% of the recipients nowadays in some heart transplant programs. But how about the others? How about the standard recipients? So recipient safety really is an argument pro machine perfusion. Why is that? Because research has shown years ago already that lactate, maybe others as well, but lactate is a very good parameter to monitor function of the heart on normothermic perfusion. And if we look at a case we've done in Hanover, that was a young lady with previous sending operation for transposed great arteries, had not a assist device, but several previous surgeries on the heart. And we accepted a donor heart with LV hypertrophy, 17 millimeters in diastole of the interventricular septum. And we were hesitant to accept that heart for that young recipient with previous surgeries, but we said by using the OCS, we have the time to do meticulous preparation surgically, but we also have the means of assessing the heart using the lactate levels, if it will be preserved well, although it has LV hypertrophy. And if we look at the values here, it has on the right, there's the bars showing the lactate levels. The lactate levels in the later perfusion phase remained very low, below 1.5 millimoles per liter. And that was the point when we decided, well, we can take that heart, although it has LV hypertrophy for this young lady. And the discharge from, so the course after the transplant was uneventful and worked out very well, and she's doing fine ever since. So that's just an example of how safety of the recipient can be increased by using machine perfusion. So we can assess extended criteria hearts. We can do longer out-of-body times, more than 8 hours. That's important for redo surgeries. Many recipients are redo surgeries nowadays. And we have more recipient safety with lactate measurements. So I will hurry a little through lung transplantation to try to keep in time. So machine perfusion in lung transplantation is done for 2 different reasons. One is extended criteria lung donors, to assess those difficult extended criteria lung donors. And there's a lot of agreement that for extended criteria lung donors, ex vivo lung perfusion is a very good tool to assess these organs. And about 40%, for example, in Germany, of all lung donors are extended criteria donors. And the other reason why we would use ex vivo lung perfusion is reduction of primary graft dysfunction, which is also a big problem in lung transplantation, and which also takes place when we use just good donors. In about 30% of all recipients, severe primary graft dysfunction comes up within 3 days post-transplant and interferes with results. And the other reason to use ex vivo lung perfusion potentially would be to reduce primary graft dysfunction. So reduction of primary graft dysfunction in the long run would also reduce not only mortality, but also bronchiolitis obliterans or a chronic lung allograft dysfunction. And what are the means of ex vivo lung perfusion we can use portable devices as the OCS lung, or there is stationary ex vivo lung perfusion. So the upper bar would be stationary. So there would an initial phase of cold storage, then ex vivo lung perfusion, then transplantation, with another second phase of cold storage potentially in between. And if we use the portable OCS lung device, we can initiate ex vivo lung perfusion earlier without a long phase of cold storage, just a short cool down, then start of ex vivo lung perfusion, and then going forward to transplant. So obviously, Shefke Chefji in Toronto really brought out the first high-level publication in the New England Journal of Medicine using EVLP in 20 extended criteria donors. Okay, so ex vivo lung perfusion becomes a pretty standard procedure in lung transplantation. That is what we see in the clinical field. Early clinical survival in the INSPIRE trial that we did internationally as a randomized trial comparing OCS and cold storage for lung preservation and standard donors. Early clinical survival was equivalent between the machine perfused lungs and the cold storage lungs in that trial, but primary graft dysfunction grade 3 incidence was within 72 hours post-transplant, was lower in the machine perfusion arm of the trial. And we have overall excellent 2-year survival. So we're obviously looking forward to see long-term results. So if this reduction in PGD grade 3 would translate into lower clot incidence in the long run in lung transplantation, something we don't know yet. But we still believe that we believe that every lung could benefit from reduced primary graft dysfunction, and we also think that every recipient could benefit from donor lung reassessment, something that I've also said for the heart, that we have a tool to assess function during preservation, and something that could increase recipient safety also in lung transplantation. So thank you for your attention.
Before moving with the next presentation, I want to remind the audience to ask questions through the Q&A button, and the panelists will answer after their rebuttal. And now we can move to the second point of view. This task will be done by Luciano Potena. Luciano doesn't need any presentation. He's one of the top opinion leaders in the field of thoracic transplantation. And he's a cardiologist from Bologna, Italy, and is the medical doctor of the heart and lung transplant program in Bologna. Luciano, thank you very much, and we will listen to your presentation. Thank you.
It's a few minutes. I will try to convince the audience that every thoracic organ should not be procured with machine perfusion, meaning that we should not consider this technology as a technology for every and each organ that can be procured. Okay, these are my disclosures. So as Massimo already said, I'm a cardiologist, so I would completely inadequate to talk about any surgical procedure, as my opponent did. So he's a surgeon, and he's one of the best experts in Europe regarding heart and lung machine perfusion. And you can see here while he is probably training, and so the attitude of having these devices is embedded in the way surgeons are looking at life and generally are spending their time. So this is why probably the idea of treating every organ with a machine is coming from. But let's see the things with more wide perspective as a clinician, if you wish. So this many of the slides I will show, and many of the studies I will show have already been shown by Gregor. And here this is again to remind you the many different devices that are available for machine perfusion. In heart, we only have one currently approved and available for organ perfusion, which is the TransMedics OCS, while in lung we have several devices that are approved, plus other numerous techniques that are homemade for lung reconditioning and lung perfusion. So as it has already been said, the main targets for machine perfusion are basically these three, and we have some evidence for most of them. Machine perfusion may reduce the injury related to cold ischemic time, may allow to assess organ quality and viability, and in particular for lung only, not for heart, it can help to recondition suboptimal organs. Why ischemic time is something that is important. We know that the lung, the heart is out of the body in the cold storage. The higher is the risk of 1 year mortality. These are the data from the HSLT registry that is showing how after 3.5 hours, the risk of death, the risk of 1 year mortality is increasing in our transplant recipients. So it's important to do whatever we can to reduce this time. But how many transplants are after 3.5 hours? And why the machine perfusion can help us to reduce this time. This has already been shown, but in this cartoon from a publication with my group and others co-authored a few years ago, it can be seen in a schematic view how the OCS, since the OCS is the only device for the heart, can allow a warm perfusion and an extended transportation time and reduce the cold storage and the cold ischemia of the heart. So I was saying how many patients can have more than 3.5 hours and receiving a transplant. These are data again from the HSLT registry. You can see here that in Europe, probably because of the countries and the different allocation system, we have quite significantly higher ischemic time than in US, than in North America and the rest of the world. If we see here in North America, 80% of organs are procured within 4 hours. In Europe, less than 60% of organs are procured within 4 hours. So we can expect that 40% of the organs have a transportation time that falls in the risky area related to ischemic injury. But it's not only about ischemic time. If we look other features of the donors, we can see that we have other differences. In Europe, we have an increasing and steadily increasing median donor age as compared to the rest of the world. It is again our data from the registry. And the interaction between ischemic time and donor age is amplifying the risk of death during the first year. We can see here in these two charts from this year, the latest registry analysis, we can see here that when we have an ischemic time more than 4 hours, the effect of donor age is amplified. And with donor greater than 50 years, older than 50 years, an ischemic time more than 4 hours has much higher impact than if, while if we have a lower ischemic time, the effect of donor age on survival is much less evident. So this is, again, this start to highlight the concept that if we want to reduce the risk of transplantation, we should try to think of a specific organ that may benefit from reducing the ischemic time and from machine perfusion in heart. Again, this is along the same lines and exploring the same concept, but looking at left ventricle ejection fraction. We know that usually we consider ejection fraction more above or below 50% as a threshold to consider a heart marginal or standard. And again, here we can see that if we have a heart with a ejection fraction less than 50% and a longer ischemic time, we have a higher risk of death during the first year, while this is not the case if we have a shorter ischemic time. So older donors and suboptimal ejection fraction are subset of organs that could benefit from OCS, while the other organs doesn't seem to be affected by reducing the ischemic time. A PROCEED-2 study has already been shown, and we can see here that these are again the same data that Gregor showed, and we see that the organ care system can significantly reduce the cold ischemia while the total preservation time is extended because we have a warm perfusion and transplantation. So this is a positive effect, but in this study, that was a randomized study, we do not have any evidence that this yield to any benefit because the clinical endpoints were not significantly different. We may argue that it was not powered, but since we are not seeing any difference on the outcome in this patient. Where we can see an advantage and a potential outcome to this potential outcome and a potential benefit can be seen in recipient who already had a complex cardiac surgery before. We have patients reached with LVAD. More and more patients are reached with an LVAD for transplantation. And transplantation in an LVAD patient is a longer and more difficult surgical procedure, and OCS can help in these cases because we have more time to do the operation. Here you can see that in this case series, it's not randomized, it's just an observational report. The mean total out-of-body time was much longer in the OCS procured organ, while the ischemic time was much shorter. What was also better, it was the need for mechanical circulatory support after transplantation. Here in this case series of comparable donor and recipient figure, much less recipient who received an organ procured with the OCS needed an MCS after transplantation as compared to the others. So this can be a benefit in this specific population. Again, the same concept has been reiterated and shown by another paper. Observational study from the London group showed that in a high-risk donor-recipient profile, we can have good survival and good outcomes if the organ is received and procured with the OCS machine. OCS has a place in the DCD procured hearts. This is the study from the group. The Australia group is the first group who proved and who published about the good results of retrieving a heart in a DCD donor. We can see here that thanks to the OCS, they were able to retrieve and transplant, to transplant effectively 23 patients out of 48 total retrieves. And we saw how with lactate monitoring and with the pressure monitoring, as has been shown by Gregor, the OCS machine can allow you to test how fit is the organ and if the organ is good enough to be transplanted. So in this case, out of these 48, 23 patients were effectively transplanted. However, we may have other techniques to recondition the heart and to test the heart and to procure the heart in a DCD donor without an OCS machine. And this is the UK, the Cambridge methodology, and which was reported here by an international group in the US and in North America, excuse me. And you can see here that this technique is based on normothermic regional perfusion, which is basically an ECMO that is connected to abdominal, in this case also thoracic organs, with a clamp in the vessels that are bringing blood to the donor. After the no-touch period and the declaration of death, the NRP is installed, the brain vessels are clamped, and then the NRP is started. And in this way, the heart can start beating again and is perfused within the body. So here we have a sort of perfusion, but it's not a perfusion by an external machine. And this can allow the organ to be reconditioned and tested, and then the organ is procured via cold storage as a standard organ. The cold storage can evolve, and we have here new devices that are coming that can help to improve the cold storage. So if we want to reduce the injury of the cold storage, perfusion is not the only technique. We can standardize the way the heart is transported and standardize the temperature the heart is transported with. We have here these devices that is coming now in the clinical use. That is not a perfusion machine, it is a cold storage machine manufactured by Paragonix that can help to transport the heart, and this is something that can be effective in standard organs and is a cold storage. Beside that, we have also new techniques that are coming. This is a perfusion machine that is not yet in the clinical scenario, but this is called perfusion, and is being on the a concept that has been developed, EVLP. And here we have the heart that has been procured and then is perfused in a cold storage machine that with a preservation solution and hematocrit solution can perfuse the heart. And this is in the clinical development and is still under research, and is something that is much cheaper than the OCS machine and can allow cold storage and cold perfusion of the heart. Moving shortly to the lung. Organ perfusion can be important, but not that important, and why I don't think that is relevant for all the organs, for all the lung that can be procured. First of all, ischemic time seem not to be much here. Of course, here we have that the p-value is patient, and we see here that if you remember the same slide in the heart, we have a much flat curve here. So the risk related to ischemic time in lung is much less relevant than in heart. So we have a less relevant issue. On the other hand, as we have seen, EVLP allows in many more actions in the lung. Marginal or initially rejected graft can be assessed. It can be used for DCD donation, increase the better donor recipient size, and specific, more importantly, specific therapy using the perfusion as a reliable platform can be implemented. In this slide, we can see a summary of the many things that can be done during the perfusion of a lung. But again, this is not something that probably not all the lungs may need this action and this drug and anti-inflammatory treatment or gene and cell therapy. This is something that can be done to reconstruct and regenerate lungs that are otherwise discarded, but not all the lungs will need or may need this kind of action. And the protocol is from one of the largest lung transplant centers in Europe, the Leuven lung transplant center. They found that 78 lungs, only 78 lungs have been selected for potential EVLP out of 500. And the main reasons that they chose to use the EVLP was reassessment of questionable injury and structural lung disease. So if we want to make a kind of algorithm, we can try to consider for lung transplantation the scenario of DBD and DCD, and we have a standard, marginal, and previously rejected organ, or controlled and uncontrolled DCD. If we have an organ that has been already rejected by others or an uncontrolled DCD, perfusion is probably mandatory to check the quality of the organ and to recondition the organ. If we have a marginal DBD donor, perfusion is recommended. Control the DCD cases. On the other hand, I believe that in standard DBD organs and in standard DCD controlled perfusion may not be strictly necessary, and actually is not strictly necessary because we have no evidence of a real impact on survival. So trying to conclude, we have a great challenge in management of thoracic organs. These are the data from NHS-BT registry, and we see here that as opposed to the other organs, thoracic organs have the greatest attrition rate from the consent to organ donation to the actual organs that are retrieved. We have 70% of all the organs are offered all the donors, in the 70% of all the organs, of all the donors, thoracic organs are offered, about 20% are actually transplanted. Graft manipulation to reduce this attrition, but we still have a substantial standard organs, and in some of these cases, perfusion can be helpful. I would like to finish with few considerations in the cost balance of organ perfusion, and these can show again why not all the organs increase the number of transplantation. We have here the standard cost per retrieval in the different techniques. The OCS is the most expensive, EVLP is averagely expensive, and we may have also a non-start cold storage that is kind of cheaper. So we have different prices, and these prices are not supporting a complete cost effective for all the organs. On the other hand, if we look how much does an LVAD cost, it costs at least as 2 OCS heart procured. So the point here is that we should not use machine perfusion to procure all the organs, but if we want to improve the outcome of our patients and keep the cost, OCS is more cost effective than LVAD, if we want to see this is another way. And coming to my conclusion, I think that the perfusion machines, OCS or EVLPs, these are great machines and very useful if you are riding in a difficult scenarios with very difficult path for the organ retrieval. But if we use in the standard highways in the standard street, we may not have a cost-effective results. In the standard organs, we may wish to use cheaper and quicker methods to retrieve the organs. Thank you for your attention.
Thank you, Luciano, for your great presentation as always. So now is the time for me to open a rebuttal. So each of the speakers can ask the other 1 or 2 challenging questions, and please take care about the time limit. So first question, Gregor to Luciano, and after that, Luciano to Gregor, and if we have enough time, maybe for the second round. Please, Gregor.
Okay, Luciano. I agree with 100% of your arguments, but I still have a question for you. So if the machine that would perfuse the heart or the lung would be cheaper and easier to use, for example, maybe comparable to the cold perfusion devices used in kidney transplantation nowadays, if it would be easy to use, less expensive, but would still add the benefit of being able to assess the heart and being sure that the heart is in good condition at the time we do the transplant, would you then reconsider your point and start thinking of every organ should be perfused?
That is a good question, and it's a good point for the future development. I showed you the main picture of a cold perfusion machine that it's likely to be and to be developed at a much cheaper than the current warm perfusion OCS, and we'll see if it's really working. Well, you know, I think that having the opportunity to perfuse an organ is something that needs to be related really to the kind of organ that we have. And we know that in Europe we are having probably less and less highly suitable and nice, clean and young organs. Fortunately, on one hand, because we have less young people dying, but unfortunately on the side of the organ recipient. So I still believe that we may not have an advantage of perfusing a standard organ, because if we have a standard organ that it's clean, that it's not that has a normal function coming from not an old donor, I don't see the point why we have to change. We reserve the organ in order to avoid accident, like the ice that is freezing the surface of the organ, that sometimes may happen. Of course, if we had cheaper machines, and machines as also in heart to recognition and to start therapies in the retrieved organ, this would favor not only a wider use of machine perfusion, but also a higher procurement of organs that are currently discarded, in my opinion, because we have a lot of organs that are discarded by fear or by insufficient data to clearly retrieved. And if we had a cheaper solution, it would be wider used, I think.
Thank you, Luciano. Before giving an opportunity to Gregor to ask Luciano something, I will ask our audience to put some questions by clicking the, you see at the bottom of your screen, questions and answers icon. So we can ask maybe both of the speakers any questions you may have. And now, Gregor to Luciano, please, a question.
So,
I mean,
it's up to Luciano.
Luciano to Gregor, sorry.
Yes, okay. So, Gregor, I have a question for the lung area. You also showed it briefly, and this is something that I tried to retrieve from literature, but it's not in my expertise, and I would like you to cover a little bit more of this topic also for the lung people that are attending this webinar. So how close are we, or if we are, how is a feasible a pharmacological treatment or a cytokine treatment of the lung retrieved with the EVLP? So how at what stage are we in really pre-treat with drugs and with procedures the lung for a standard recipient? I mean, because something this is around experimental is doing something with the immunosuppression and with the induction of tolerance in the organ that is sitting there and is perfused. So at what stage are with the development of this treatment with lung?
Yeah, so
is doable, or it's something that is still in the lab?
Yeah, so the answer is rather easy. So it is doable, and it really depends on the drug you're intending to use. So we have, for example, in Hanover, we have started a protocol, and I know that other centers have also started these protocols with specific antibiotic treatments. For example, if in Germany, we receive from time to time lung offers from, say, Greece or other Southeastern European countries with very high multi-resistant drug bacteria colonizing the donors. So there are areas where 80–90% of the multi-organ donors are colonized with multi-drug resistant bacteria. And well, the easy way would be just to reject these lungs, obviously, but we have started using the OCS and colistin, high-dose colistin in recirculation in the device, combined with intratracheal or intrabronchial application of colistin. Also, other antibiotics are potentially usable at doses that are above the level that would be used in humans or in intact patients. So we can use high dose antibiotics for that, and we've actually did this a few times in Hanover. There are other protocols ongoing. I mean, for example, deleting the hepatitis C virus by photopheresis treatment, as the Toronto group was doing. They have a clinical trial now ongoing with a IL-10 gene transfer in human lungs, something that is obviously a long path to introduce clinically because of the implications of getting permission to do these gene modification studies in humans. But it's not the problem of the ex vivo lung perfusion machine. It will do that, and it is already doing that in those centers that use this. So I think it's more about now introducing the study protocols for specific drugs to be used in the device. And as I said, there are several of these trials now ongoing. And I think it's something that will increase and increase in the next, well, in this year and in the next few years. So it's something that is already done clinically and will increase to be used clinically.
Okay, Gregor, due to the time limit, I think we have to move to the questions and answer session. So Massimo, will you please proceed with the first question from the audience? I think we have time for 1 or 2 questions.
Okay, thank you very much, Ivan. There is 2 questions. The first question is, how much should we willing to pay more for a transplant to have decrease of primary graft dysfunction by 20 or 30%? Good question.
Yeah, very good question. Who will answer? Who will try to answer, but very quickly, please. I mean, if we count the very low number of primary graft failure, primary graft dysfunction after a transplant, how many machine perfused grafts should be used to decrease that number by 20 to 30%? Well, what do we have to ask?
So I may try to give an answer.
Okay.
So, well, I'm a surgeon and I'm a clinician and not an economist. So I'm usually saying if it's doing something good for the recipient, I don't care that much about cost, and the payers will have to find a way how to pay it. The more relevant question is if we have a incremental decrease in primary graft dysfunction in lung transplantation by using machine perfusion, we really want to know. I think it has to translate into something. For example, decreased mortality or decreased rate of chronic rejection. If we can measure that, even if it's only by 20%, I think it would be justified to do perfusions. As long as we only have a decrease of primary graft dysfunction without proving that survival or chronic graft rejection or other things hampering the recipient in the long run are not really changing, I don't think we have the full justification. You know, so it's not about the 20-30%. It's more about the final outcome for the recipient. If we can measure that, I think we have to pay it.
Okay, that's great answer, but not everybody is living in Germany. I mean, with a great economy and a lot of money in a health system. Let's say in our country, we'll get an answer, okay, but if we give more money to every transplant, that means less transplants will be performed annually. So probably that's the case in many countries. I don't know, do we have time for another question? We are 1 minute to 7 o'clock. No, I think we have an answer. Thank you. So we're going to skip the second question, which was very nice. And I like to, yeah, thank you, Andreas. I like now to really to thank both speakers for excellent presentations and for rebuttal, and the audience for participating. And there is one more very short poll you have to answer at the end. And please, I like to ask you first What is, did you change your mind? Yes or no? Every thoracic organ should be procured with machine perfusion? Yes or no? Panelists cannot vote. Gregor, don't press the button. Okay. Okay, instead of 75, good work for Gregor, we have only now 64% of no. So like 10% of the people change their mind. And that's very nice. And there is another poll, the last one. What do you think about this webinar? And I'd like to invite you to register to TLJ and there will be some more exciting sessions available. What do you think? How useful for your professional activity was this event? Extremely useful, useful? Probably those two will not be a case, not useful now. I think only extremely useful or useful. Oh, great. Extremely useful. As I said, extremely useful for 71% and useful for 29%. Massimo, do you have to add, or do you think you can add something, or close this session?
I think that we had a very exciting webinar, a very exciting debate. And I want to thank Gregor and Luciano for their excellent presentations, and many thanks also to all the attendees. I would conclude saying that the good sense still won. Perfusion technologies are important tools that we can use to improve our outcomes in selected cases. And I think that this procedure are helping us to push a bit forward the limits of our clinical practice, introducing more quality in the graft that we transplant, despite they are initially suboptimal while in the body, in the donor body. I want to thank you very much again, and please, Ivan, if you want to conclude the webinar.
Thank you. I'd like to thank my co-chair, speakers, and the audience. Thank you and goodbye.
Thank you.
Bye-bye.
Thank you.